Just by looking at these two four-chamber views, you will immediately recognize that these two patients have completely different pathologies. This is apparent because the heart chambers look different and because their function is different. In this chapter, we'll be talking about the heart chambers and walls. We'll find out more about their physiology, how to quantify them, and also how pathological states can actually alter the heart chambers. Ever since the writings by William Harvey in the 17th century do we know that the left ventricle is in the center of the circulatory system. The left ventricle is not here to heat the blood, as has previously been thought, but to pump the blood to the organs. But the left ventricle is a very complex structure which has a very unique physiology. We'll find out more about the left ventricle now and what its role is in different pathological states. The shape of the left ventricle has always been compared to that of a bullet. Geometrically, it has the shape of a truncated ellipsoid. This is important to know because a number of pathologic states can alter the shape of the left ventricle, and only by looking at the still image, even without looking at the function of the heart, you can, for example, determine that the patient must have a pathology, for example, a cardiomyopathy patient who has a more rounded shape, an aneurysm, a Takotsubo disease, we'll be talking later about what Takotsubo is, or an apical hypertrophic cardiomyopathy. This is an example. On the left, you see a normal left ventricle, the truncated ellipsoid shape with a fairly long and narrow left ventricle, while on the right side, you see the typical rounded shape of a dilated cardiomyopathy. Since the left ventricle is such a prominent structure, you will visualize the heart in many views. And actually, you should use as many views as possible to get a good appreciation of the size and function. You can use the peristernal long axis view, the short axis view, and apical views such as the four-chamber view, the three-chamber view, and the two-chamber view. To quantify the size of the left ventricle, in principle you have two possibilities. One would be to measure the diameter, and the second would be to measure the volume. The diameter of the left ventricle has traditionally been measured using M-mode from a peristernal approach. But you can also measure diameters using the four-chamber view, for example. The following demos will now show you how to measure diameters of the left ventricle. To perform an M-mode measurement of the left ventricle, you need a peristernal long or short axis view. You can actually do it from both. I will show you how to do it from the short axis. So the first thing you have to look into is if the ventricle is really round. This is important for the reasons already mentioned. So once you have a nice view of the left ventricle, you will put the M mode exactly through the middle of the left ventricle and optimize the image so that you have a very good contour, and then freeze the image and perform the measurement of the septum at diastole. So we have the biggest width of the left ventricle shortly before the QRS complex starts. So this is where you would start with your M-mode measurement of the septum. Then you would measure the end diastolic diameter, the posterior wall. Now all these measurements are diastole, and you would then perform the same measurements at systole for the end systolic diameter, for the posterior lateral wall, and these are the measurements basically that you would perform. This is an example of an M-mode measurement of the left ventricle. You can see that we measure exactly at the end of diastole, in other words, at the beginning of the QRS complex, and where the left ventricle is at its largest. We measure from the endocardial contour of the septum to the endocardial contour of the posterolateral wall. The diameter we get in this case is 68 millimeters. As you will see later, this is a dilated left ventricle. However, be careful when you perform M-mode measurements of the left ventricle. It is very important that you get a perpendicular orientation of the M-mode beam to the walls of the left ventricle. If you don't get that, you might have a diameter which is too large, where you overestimate the size of the left ventricle. Another problem you might have is that the M-mode quality is not appropriate and that you cannot get a good delineation in the 2D image and therefore also not in the M-mode image. To perform M-mode measurements in all patients, I personally rely more on the 2D measurements of the left ventricle. 2D measurements of the left ventricular diameter are quite simple and easy to do. I'll just show you how one can perform this measurement. First of all, use a 4-chamber view, freeze the image, and end diastole, and also consider that the endocardium is located more medially and that this is not the endocardium here, but that this is the endocardium. And then you would just measure parallel to the plane of the mitral valve towards the interventricular septum, and we will get a measurement of 46 millimeters. If you do not get a decent 4-chamber view, you can also perform the measurement from a subcostal approach in a 4-chamber view, or you can also perform the measurement, for example, in a short axis view of the left ventricle, parasternal view. So you have more options than the 4-chamber view. What are the problems associated with 2D measurements? Well, lateral image resolution is certainly an issue. However, in most patients, even if image quality is not very good, you can still delineate the lateral wall. What is more important is that the diameter measurements do not account for mid and apical shape changes of the left ventricle. These are the normal values. As you will see, values are obviously smaller for females than for males, and there's a fairly wide range within the normal values. You can find these normal values also in your fact sheet. Because there's such a wide range, and because the diameter is very much dependent on the body surface area, it's better to use an indexed normal value for left ventricle diameter, which is indexed to the body surface area. So these are the normal values. Again, you will find them in your fact sheet. I want to give you this short example just to help you understand why the volume is more sensitive than the diameter if you want to really describe the size of the left ventricle. Let's take a cone as an approximation for the shape of the left ventricle. If you want to calculate the volume of the cone, what you need is the radius. But to get the volume, you have to square the radius and also multiply it by pi to get the true volume. So any small changes of the radius will make a fairly large change in the volume of the left ventricle. So measurement errors will have an exponential effect on the volume. To quantify the volume of the left ventricle, we use the so-called method of discs, or also called Simpson method. The principle is very simple. All we are doing is we're interpolating a number of discs into the left ventricle, and if we also know the length of the left ventricle and the thickness of these discs and the diameter, either in a 4-chamber view or in a 2-chamber view or in both, we can calculate the true volume of the left ventricle. Let's see how we do that in clinical practice. To quantify the volumes, the most important thing is to get a good image quality of a 4-chamber and a 2-chamber view. So I'll show you some of the pitfalls or some of the problems. One problem usually is that we do not get a good resolution in the lateral wall. So often it's good to have the patient exhale a bit. And then once you get good image quality, let's increase the gain a bit, we can freeze the image. Now sometimes we have difficulty to really determine where the endocardium is. It's usually easier if you move the trackball and the frames back and forth, because you can appreciate the contours better in a picture that is moving. And if you remember where the contour is, you will find it easier to track the contour then. So I will go to the measurement program and then I will trace the contour. And
and trace it all the way to the annulus and then close the contour. You have the length which is given in this program, and then you just agree that this is truly the length, and you will get an end diastolic volume of 79 milliliters. So very important, try to get a good image where you do not have too much papillary muscle, so you can rotate the transducer a bit to get rid of the papillary muscle. You see, this would be the papillary muscle, and if you do have a papillary muscle in your image, you should just transect it. Do not contour the entire papillary muscle. Let's now go to the two-chamber view. Bisschen einatmen, ausatmen. So this would be a fairly good two-chamber view. And again, would contour the left ventricle. We're cutting the papillary muscle here, and we get 74 milliliters, which is a normal sized left ventricle.
These are the end diastolic volumes of the left ventricle for males and for females. You can see that the volumes are obviously larger for males than females, and that there's a fairly large variation in the size of the left ventricle. In addition, you will see that a volume above 200 to 250 denotes a severely dilated left ventricle. Here are the end systolic volumes, and these are the volumes when we index them to the body surface area. I would prefer to use these measurements. Other measurements I'm showing here can also be found in your fact sheet. Sports also increases the size of your left ventricle. However, to really increase the size, you have to perform excessive sports. In other words, you have to be a professional athlete who does at least cross-country skiing, or you have to be a cycler. Let's now take a look at left ventricular function. For the ability of the left ventricle to eject blood, a number of factors play an important role. Contractility, the shape of the ventricle, preload and afterload conditions, and importantly, as you will later see, myocardial mechanics. It is also important to understand that a reduction in ejection fraction is way at the end of the cascade of left ventricular dysfunction. At the beginning, we usually have a reduction in contractility, which is also influenced by pre- and afterload. This is compensated early on by an increase in sympathicus tone and by dilatation of the left ventricle. Left ventricular dysfunction might only become apparent at the beginning by a reduction in stroke volume during exercise, and only late in the cascade will we see a drop in stroke volume also at rest. In reality, the base and the apex rotate in opposite directions. With the help of modern echocardiographic techniques, we can actually measure this motion. We call them twist or torsion. With these techniques, we've also come to understand that there are different components of contraction. The radial component, which is directed inwards to the center of the ventricle, the circumferential motion, which gives the heart a certain degree of twist, and also the longitudinal component, which is directed from a base to the apex and vice versa. We have to keep these factors in mind when we interpret left ventricular function. But let's now see which parameters are available for the quantification of left ventricular function. Fractional shortening, eyeballing and estimation of left ventricular function, calculations of ejection fraction using the Simpson method, calculations of stroke volume, cardiac output and cardiac index, contractility measurements using DPDT and the TI index. These are the standard parameters we use in everyday clinical practice. But there are new parameters also on the horizon. We can use tissue Doppler, 4D echocardiography, and importantly also deformation parameters such as strain and strain rate. In a special section, we'll be talking about these parameters later. Let's first take a look at fractional shortening. Fractional shortening is calculated from M-mode measurements of end diastolic and end systolic diameters. You calculate the fractional reduction between the diastole and systole, and you end up with a percent value. The normal value for females is above 27% and for males above 25%. You can approximate ejection fraction if you just multiply this value by 2, but remember, this is only an approximation. There are a number of limitations of this method. Where does fractional shortening not work? It does not work if you have left bundle branch block. Why? Because you have premature contraction of the septum, and you have a contraction in the septum and the posterolateral wall at different time points. You have the same problem if you have abnormal septal motion due to other reasons, for example, right ventricular pressure overload or volume overload. And you also have to be careful in situations where you have regional wall motion abnormalities, because this can lead to either over or underestimation of ejection fraction or fractional shortening, depending whether you have the region of infarction or regional wall motion abnormality within the ultrasound beam or not. Another problem that you have to be aware of is a methodological problem. Especially if you have small left ventricles, you could get lateral portions of the myocardium, and in particular the papillary muscle, within the field of the M-mode, and thereby this leads to a pseudo shortening of the left ventricle, and thereby you would overestimate ejection fraction. So this is another problem that you have to be aware of. Theoretically, you can calculate ejection fraction from fractional shortening using the so-called Teichholz formula. This formula relies on geometric assumptions, and it is not very reliable and only works in patients who have normal sized and normal functioned left ventricle. So in reality, you should not use this formula. There have always been discussions what should be preferred, eyeballing of left ventricle function or measuring of left ventricle function. I personally think that both should be used, and that it always depends also on the experience of the observer and the echocardiographer. So in many situations, we'll have to rely on measurements, but in other situations, we'll have to rely on eyeballing. I want to show you these image clips to help you get a better feel for the different degrees of left ventricular function. On the left-hand side, you will find a hyperdynamic left ventricle. This is a patient who has a normal left ventricular function. Here it may be difficult to see a patient who has moderately reduced left ventricular function. And I think you all will agree that this patient has severely reduced ejection fraction. Again, compare the different degrees of left ventricular function. And now we'll take a look at an apical four-chamber view. Again, on the left-hand side, a hyperdynamic left ventricular function. Normal ejection fraction, normal function, mild to moderately reduced left ventricular function, and severely reduced left ventricular function. You will immediately see that it is not difficult to distinguish the hyperdynamic from the severely reduced or the normal from the severely reduced. The problem usually lies here in the middle, where you have mild or moderately reduced left ventricular functions. And especially in these cases, it will be necessary to use other modalities as well. A few considerations. Left ventricular function appears better than it is in small ventricles. This is important, for example, in patients who have hypertensive heart disease and who have hypertrophy in small ventricles. In this case, as you can see here on the top, ventricular function has to be hyperdynamic because they have small end diastolic volumes. So they have to be hyperdynamic to be able to eject enough blood. Another pitfall, patients with left bundle branch block appear to have a poor left ventricular function than they actually have, simply because contractility is desynchronous. And one other thing to keep in mind, always also look at longitudinal contraction. In other words, in contraction not only in the radial direction towards the middle of the ventricle, but from apex to base. Volume overload is a situation where we have both a dilated and a hyperdynamic left ventricular function. We will meet this state in several clinical situations, such as aortic regurgitation, mitral regurgitation, but also ventricular septal defect. We already saw how we can calculate volumes using the Simpson method. Now we'll see how we can use this information to also calculate the ejection fraction.
To quantify left ventricular function with the biplane Simpson method, you need a good 4-chamber view. And we do the same thing as we would to quantify the volume. We trace the endocardial surface, omitting the papillary muscles. And we do the same thing for systole. Okay, systole, it's usually easier to track the endocardial surface. And we get an ejection fraction of 66, which is normal.
So these are the normal values for ejection fraction with echocardiography. Everything that is above 55% is normal. What I don't really like about this scale is that we do not further discriminate ejection fraction below 30%. You will find patients who have ejection fractions far below 30%, for example 5, 10% even. And I believe that these patients have a much poorer prognosis than those who have 30%. What are the limitations of the Simpson method? It might be difficult to find the endocardial borders. The volumes itself sometimes might not be correct because we have foreshortening of the ventricle. However, this is true both for end systole and diastole, so this kind of evens out. It is only an approximation of true volume, especially because the posterolateral and the anterior septal region is not considered. So if we have scars there, we will not have them in our calculations of ejection fraction. And similar to the M mode, dyssynchrony is a problem because it is difficult to time diastole and systole if the ventricle does not contract in all regions at the same time. Aside from the Simpson method, we can also use hemodynamic parameters to calculate left ventricular function.
The most important part of measuring the stroke volume is the measurement of the LVOT diameter. To get a good measurement, you have to increase the resolution and try to see that you have the aortic valve nicely in your image. Then you freeze the image and measure the LVOT exactly during systole, so when the valve is open, just below the aortic valve. So in his case, we're getting a diameter of approximately 24-25 millimeters. And then the next thing you would need is you need a good pulsed wave Doppler signal, which you can get from an apical approach. So we'll try to do this here. 5-chamber view. You see that I'm trying to get a view where you have a good orientation to the ultrasound beam again. I place the pulsed wave Doppler signal just below the aortic valve in the middle of the LVOT. Then I freeze the image and then I just simply trace the LVOT curve. And I also move to the next beat so that I get the heart rate. And what I get is a stroke volume of 97 milliliters, which is normal. And by also incorporating the heart rate, we can get the cardiac output, which is 5.9 liters per minute. So this is a completely normal hemodynamic situation.
Just to review, you need two things. First of all, the LVOT diameter, with which you can calculate the cross-sectional area. And then you multiply the cross-sectional area with the time velocity curve that you get with the pulsed wave Doppler. There's an alternative method to calculate the stroke volume simply by subtracting the end diastolic from the end systolic volume, which you can get with the help of the Simpson method. The normal values for stroke volume at rest would be somewhere in the range of 70 to 110 milliliters. With exercise, stroke volume increases to approximately 130 milliliters and the cardiac output increases to 17 liters from 8.5 simply because you also have an increase in heart rate. And these are the values for the cardiac index. Again, you will find all these values in your fact sheets. So what are the limitations? Well, there's always some degree of beat-to-beat variation, especially in patients who have atrial fibrillation. In these patients, you should average several beats. Another problem is that even small measurement errors of the LVOT make a fairly large difference with respect to stroke volume. You cannot use this measurement in patients who have aortic regurgitation, and you have to beware in patients who have aortic stenosis, because if you measure the maximum velocity within the area of stenosis, you will obviously overestimate stroke volume. Another way of looking at left ventricular function is contractility. Contractility is measured with DPDT, and it describes how quickly the left ventricle is able to increase its pressure during systole. This is the formula for DPDT, and now we'll see how we perform this measurement in clinical practice.
What we need for a good DPDT is a good regurgitant signal, and this patient has such a good regurgitant signal in that the MR is very centrally localized and not eccentric in its direction, very nicely oriented to the ultrasound beam. We then place the continuous wave Doppler spectrum right through the regurgitant jet. What we also try to do is we try to optimize the focus point to the origin. And then we have a signal like this. And what we do is we try to increase the time scale. And then we have a nice signal. What is nice about the signal is that we have a good discrimination here, especially of the beginning of the curve. This here is not so nice, but this does not really affect our measurement. So this is what you need to get: the early systolic phase of the regurgitant jet. And then we would measure the velocity between 1 and 3 meters. And this would then give us the DPDT, which is very high, 4,327. So the patient has hypercontractile function. He's probably very anxious at the moment. What I also want to show you, however, is that the measurements are very strongly affected by small measurement errors. So for example, if I just change the cursor very slightly, I get very big differences in DPDT. So this is one of the limitations of DPDT, and you have to be aware of these limitations, and obviously you have to really be exact in your measurements.
So these are two mitral regurgitation signals. On the left-hand side, a patient with a normal DPDT. You can see that the steepness of the curve is fairly steep, opposed to this patient where there is a reduction in the steepness and therefore also a reduction in the DPDT. We measure between 1 and 3 meters, the time interval, and then plot this into the formula, and then we get DPDT. What are the normal values? Well, basically there's a certain degree of overlap, but if we have a DPDT which is above 1,200, it is normal. Some patients who have hyperdynamic left ventricles, we can find DPDTs way above 1,200, sometimes even 2,000, 3,000, or 4,000. If we have a DPDT below 500, the ventricular function is usually severely reduced. Unfortunately, this calculation has a number of limitations. I've already mentioned that you need an MR signal in the first place, and that this signal must be a good signal, especially the initial portions, to perform the calculation. But I still believe that the major limitation is the fact that even small measurement differences make a large difference with respect to the value you get. In addition, it is probably not completely load independent. So we've seen a number of ways to calculate left ventricular function and to look at the left ventricle. None of them are really ideal, but I believe if you put all these together as the little parts of a puzzle, you can finally arise with a correct estimation of both size and function of the left ventricle.